So welcome to the Movement Disorders Society of India author podcasts, where we interview lead authors of interesting and landmark papers from India. I'm Dr. Divyani Garg. I'm Assistant Professor of Neurology at Lady Hardinge Medical College, New Delhi. And today I'll be conversing with Dr. Roopa Rajan. She's Assistant Professor of Neurology and a Movement Disorders Neurologist at All India Institute of Medical Sciences, New Delhi. And we will be chatting about her recent publication in JAMA Neurology titled Assessment of Botulinum Neurotoxin for Dystonic Hand Tremor, a randomized clinical trial. So this is a randomized clinical trial of 30 adult patients with dystonic tremor, and significant differences in terms of tremor severity were found at 6 weeks in favor of botulinum neurotoxin. So let us get into the details of the study with Dr. Roopa. Dr. Roopa, thank you so much for joining me here at this podcast. A very warm welcome to you at this very first podcast of the MDSI.
Thank you very much, Dr. Divyani. It's a real pleasure to be here, and I am very happy to see this initiative, and thank you so much.
That's great. So what are some of the gaps in literature with respect to dystonic tremor, specifically with respect to the treatment of dystonic tremor? And thereby the second question, which is, how did the idea behind this RCT emanate?
Yes. So as we know, dystonic tremor is one of the not so uncommon tremor disorders that we see frequently in the neurology and movement disorder clinic. So we say that somebody has dystonic tremor when they have dystonia and tremor affecting the same body part. So if we talk about dystonic tremor, it can be a dystonic head tremor, a dystonic hand tremor. Sometimes they can have voice tremor. And the axial dystonic tremors, especially the head tremors and the voice tremors, respond quite well to botulinum neurotoxin. But when it comes to the hand tremors, there is definitely a large gap in meeting the patient's needs for effective treatment and control of these symptoms. And especially the hand tremors are quite disabling. And so far, the management strategies have been sort of three-pronged. The first one would be medications, and the ones that we usually try are like trihexyphenidyl, propranolol, those that are used for the treatment of primidone for essential tremor, but the responses in dystonic tremor are only modest. And many patients with severe generalized dystonia or dystonic tremor may undergo deep brain stimulation, which is at the other end of the spectrum, a very invasive therapy. But for those patients in between, really there has not been much evidence for effect of treatments like botulinum toxin. So if you look at the literature in the last few years, there has been a lot of evidence coming up for botulinum toxin in other related tremor disorders like essential tremor and even Parkinson's disease. And a recent review by the Movement Disorder Society has classified botulinum toxin as a possibly useful treatment for essential tremor. So this idea of looking for the effect of botulinum toxin on dystonic hand tremor arose from this background, that it is useful in these two other probably related tremor diseases, tremor conditions, and that there is no really effective treatment for dystonic hand tremor as such. So, and there are case series that have reported some benefit of dystonic hand tremor with botulinum toxin injections, but no real randomized controlled trial that has looked at this.
Okay, so that's great. So what are the major concerns with the use of botulinum toxin for upper extremity or hand tremor? Based on your previous experience, of course, and literature, and how did you try to circumvent these in this particular study?
Yes. So the main concern, of course, with using botulinum toxin for hand tremors is hand weakness. So many studies have assessed the effect of botulinum toxin on essential hand tremor. And they have sort of found that although it may be an effective treatment, the hand weakness sort of limits the functional abilities that a patient can gain from this treatment. So the major concern was limiting the hand weakness. And for that, if you look at the literature and also clinical practice in centers worldwide, we have sort of moved from a fixed dose approach in which fixed doses were injected into the extensors and the flexors of the wrist or the hand. And from that, we have sort of moved on to a customized or an individualized approach. Depending on the tremor phenomenology, we choose the muscles and the doses, and of course, guide the injections probably using EMG. And in this particular study, we also tried to limit the hand weakness by trying to limit the doses to the extensors,
Right.
because we know that the extensors of the wrist and the fingers, especially the extensor digitorum communis, these are exquisitely sensitive to hand weakness with botulinum toxin. So we tried to limit the doses to these to almost half the dose that was delivered to the flexors.
Right.
And with these, we tried to limit hand weakness.
So April 11th is World Parkinson's Day, and on this day, the MDSI would be conducting public awareness campaigns on Parkinson's disease. So do watch out for those.
Okay. Another thing I noticed is that you have used a parallel group study design as opposed to a crossover a design that is the usual practice for botulinum toxin studies. I mean, they mainly use crossover study design. So what was the rationale behind using this, and how did it benefit your objectives for the study?
Yes, thank you very much for bringing this up, because I felt this was a very important point when we were planning the study. Many studies using botulinum toxin have used a crossover approach, but the effects of botulinum toxin, as we know, can be quite unpredictable in an individual patient. So although the known duration of action that we expect is maybe 3 to 4 months, in some patients the effects wear off much earlier, and in some it may last 4 or 5 months or so. So these would translate to carryover effects in a crossover trial. To decide an adequate washout period would be difficult, and if you are left with any kind of carryover effects, at the end of a crossover trial, then the analysis becomes really complicated.
Right.
So that way, we decided to choose a parallel group design, and which I think worked very well for us when it came to analysis.
Absolutely.
Yes.
So what was the profile of the patients included in the study, and who did you exclude?
Yeah. So we included major inclusion criteria was that they should have brachial dystonia with dystonic tremor. And this could be in the setting of either a focal dystonia, a segmental, or a generalized dystonia. And they should be more than 18 years of age, and should consent to being part of this study. And they should not have received botulinum toxin injections for the last 4 months if they have received it before. We kept this inclusion criteria kind of broad, and we only excluded patients who had definite evidence of Parkinsonism or cerebral ataxia that would suggest an alternative diagnosis. And we didn't limit it to patients with only focal or segmental or generalized dystonia. So we screened about 48 patients during the duration of the study, and we excluded about 18, and we were left with 30 patients, and with a mean age of about 46 years and a mean duration of illness of about 8 years. And about 86% of them were male.
Okay. So you have explained quite a bit about the approach that was used, but can you tell us a little more in detail that you used a customized approach and, of course, limited the dosing to the extensor muscle? So was it a single person injecting these patients? Exactly how did you go about the approach for the botulinum toxin?
Yes. So we used a customized or an individualized approach to injections, and we gave EMG guided injections. So the muscles were selected according to tremor phenomenology.
Okay.
So these patients, as part of baseline evaluation, we did a standard video protocol examination. I mean, these examinations were videotaped, and then they were reviewed to identify the major tremor locations across which joint, and we saw indirectly which muscles are likely to be involved. And depending on that, we on the clinical examination, we chose which muscles to inject. And then to ensure that we are in those muscles indeed, we used EMG guidance. For dual delivery, the doses we did. There are no definite guidelines about what dose to use, but we did follow some previous studies who have used similar approaches. And in our study also, the doses that we used are given as a supplemental information so that it can guide future use. And a single trained injector injected all the patients.
Okay. So what were the primary objectives and the secondary objectives in this RCT?
Yeah. So the primary outcome of this study was the total FTM TRS score. So we were interested mainly in assessing the tremor. So this is a very validated scale, Fan-Tolasa Marin scale for a broad spectrum of tremors, primarily intended for essential tremor, but it has been used in other studies of dystonic tremor as well. And we used the total score as the primary outcome. So this has three parts. Part A and Part B are objectively rated, and Part B includes some specific motor tasks like writing, pouring, and drawing a spiral. And Part C is a patient-reported outcome. So this was our primary outcome. As a secondary outcome, we analyzed the subcomponents of the FTM-TRS score. Also, we looked at the dystonia because all these patients had dystonia. So for dystonia, we used the writer's cramp rating scale to look at dystonia while writing. We used accelerometry to objectively quantify the tremor. We used a triaxial accelerometer with EMG. And to look at the grip strength, we used a dynamometer. In addition, we also included a patient global impression of change scale to get a subjective idea about how the patient feels after this injection.
Okay, and the outcomes were assessed at 6 weeks and then at 12 weeks. The secondary outcomes at 6 and 12 weeks. The primary outcome was assessed at 6 weeks.
Yes, the primary outcome was assessed at 6 weeks because we expect the maximum effective bond to be around there. Yes.
6 weeks. Okay. So the paper says that basically what you found was that there was a mean adjusted difference of 10 points in favor of botulinum neurotoxin on the FMTRS. What does that clinically mean? And what were the other major findings in the study? And how many patients reported hand weakness? And was this significantly different between the groups?
Yes. So this 10.9 unit difference, we could consider it as a moderate clinical improvement, because there are previous studies that have shown that about a 5-unit improvement in FTM-TRS is probably clinically significant, and 5 to 10 is mild improvement, and more than 10 is moderate improvement. In terms of percentage of amplitude change, there is a formula that has been developed by Elbel et al. So if you use that, this would translate to about a 69% reduction in the tremor amplitude compared to baseline at 6 weeks. So, yeah.
Okay. So the MDSI will be organizing a virtual conference in May 2021 coming up soon. Watch this space for more details and announcements.
Okay. So another thing that I wanted to ask you, and I think that a lot of our listeners would be interested in this, is that this RCT was conducted in our setting, which is a resource constrained setting. So what were some of the challenges with respect to that particular setting, and how did you go about assuaging those challenges?
Yes. So thank you very much for asking that. So I think this was my first experience with, investigator initiated and academically funded RCT as well. So there were, but I think I had a lot of support from the entire team at AIIMS New Delhi. Right from my senior colleagues, Professor Prasad, Professor Padma, Professor Vinay Goyal, and Professor Achal Srivastava, who were, really involved right from the inception of this. We have a very good statistical team who could help us in planning this, in doing the randomization. In my experience, it requires a little bit of, logistics, and you cannot do it as a single person. You definitely need somebody to do the randomization for you. You need someone who is blinded. The allocation has to be masked, but these things can be done. And if you have with a team, these things are achievable. And even if it is a small scope study, I think it is important that we stick to these principles, so that the data that we bring out, it should have good value. So this is possible in India, and of course funding is the other thing. So I must say that I was generously supported by intramural funding from AIIMS, but that covered the cost of the medication. We had the tremor analysis equipment was already from another funded project, and research staff funding was also from SERB. They were in other projects from DBT and SERB. So, but finding the funding to do is part of solving the problem. But I just, so these are feasible, and I think that is the biggest takeaway that I got from doing this study myself. That when I started, I was also not sure whether how it is going to go, but it is possible. Yeah.
Absolutely. I mean, the work speaks for itself, I have to say. And based on your study, what do you think the future focuses of research need to be in terms of dystonic tremor treatment?
Yes. So definitely now this gives us an additional option to, offer to patients who have dystonic tremor. I would say that the first line management would still remain medications when the patient walks into your clinic. But for somebody who doesn't respond, which would be a large number of patients with dystonic tremor, this is an additional option that we can discuss with patients. And it does seem to be effective and acceptable to patients. And I'm sorry, we didn't discuss about the hand weakness. Yeah, so about 40% of patients reported some form of hand weakness in the botulinum toxin arm, with about nearly 30% reporting the same in the placebo arm. But it was a significant weakness was reported only by 1% in the botulinum toxin arm. So the others, it was comparable. And when we assessed the weakness objectively with a hand grip dynamometer, there was no difference between these groups.
Okay.
There was also no difference in the duration of weakness or in the the patients reporting weakness overall between the two groups.
Okay.
So with individual approach and EMG guidance, I think this is a safe and effective therapy that we can offer to patients. Long-term effects have to be studied further. So that is where the scope for future research comes, because as we offered a second round of open label botulinum toxin
Yeah,
to these
that's right.
patients.
Yeah.
So we realized that doses we can adjust better, and maybe the second injection worked a bit better than the first one. So with multiple injection sessions, outcomes may be even better, or whether they are the stability is maintained has to be assessed in future studies. Also, how much does it improve the quality of life of the patient? That is another outcome that we should be trying to capture a bit more comprehensively. So these are, I think, questions for future research that remain open at this time.
Okay. Okay. So that was my final question. And Dr. Roopa, thank you so much for joining me today at this podcast and for your very inspiring work and also your insight into your own work, which I'm sure is of immense value to all who are listening. And this is me from MDSI. Welcome to the first podcast. Thank you for tuning in. We will be back soon with more episodes. So stay tuned. Thank you.
Thank you.